evening meal. And what's immediately obvious from this is actually, if you look at the median hasn't actually moved hugely, but the variability has reduced very significantly. So this lady is now in a position where we can make a therapy adjustment, and I would look at this and say, if you look at the right half of the slide, she's getting a bit of a falling glucose level in the first part of the night, which rises in the second part of the night. So I actually think this lady's next step would be to give her, for her evening meal, a normal mix, but to use the mix 50 for breakfast and lunch. And it makes making decisions like that much more straightforward when we're looking at the profile as a whole. So the 50-50 type mixes, I think, can show a number of benefits. They can produce a better decrease in the overall glucose mean, a better reduction in A1C, a smaller postprandial glucose variability, and overall improvements in glycemic control and hypoglycemia risk. So we have to weigh up the pros and cons of twice daily approaches and multiple daily approaches. The basal bolus approach is considered our standard, but it only gives the flexibility that most of our patients want from basal bolus, which is, I can eat what I like when I like, which is the selling point for basal bolus for most of our patients. It only gives that for an individual doing carb counting. If somebody has fixed dose insulin, it only gives half of that story. It's, I can eat specific amounts of food whenever I like. So if we look at the head-to-head against the 50-50 mix and basal bolus therapy, and this is a study that was performed in 2008 in the US. Here is the whole data set, achieved A1Cs at baseline for two groups of patients who are going to be included in this study. And what we can see is that the median of their A1Cs is somewhere in the 8.5 to 9 range, and that the overall distribution is very similar between the two groups. Randomized, one therapy or the other therapy, how does that change over time? Well, at 12 weeks, the whole curve moves to the left, so they've now both got a median in the roundabout 7 mark. And at 26 weeks, it's moved a little bit further to the left. Not a lot further to the left, but at the 24-week process, some patients on MDI are doing a little bit better than some patients on 50-50. But when you look at the overall shape of the curve, they're doing very well. So I think what this reflects is those patients who are going to be very good about their self-adjustment processes and their engagement with the process may well do slightly better on MDI. But otherwise, from a population perspective, the 50-50 mix actually gives a very similar outcome glycemically to true basal bolus. And when we look at the profiles achieved, again, the profiles are similar. Although with my reflection, but as an 8-point profile, it's not necessarily as useful a profile as we might like. But again, hypoglycemia is very similar between the two groups. And actually, quality of life scores are slightly higher for those patients on the 50-50 mix as opposed to the MDI. So I think it does leave us this question, doesn't it, about, well, what should we do when somebody is already on MDI but not doing very well? Because that person usually gets quite demoralized because apparently it's our gold standard therapy, but they're not doing very well. So I actually think it's entirely reasonable, looking at the bottom right of this slide, to say, well, actually, stepping back from basal bolus therapy might be a very appropriate thing to do because we have evidence that other therapies are as effective, and it's usually behavioral elements that will make one therapy better for one person than another. So I'd like to show a last data slide of a person who is on MDI and not doing terribly well. And this is Sydney. He's on overall reasonably high dose of insulin. He's on glargine 50 units a day and takes a fixed 10 units with each meal. And you look at the profile, and if you just looked at medians, and the average, his average is 9.8. So his A1C, if we were calculating it from his average, is probably only about 8.1%. But that's disguising his main problems, which are 3 nights out of 10, he is hypoglycemic, and his range at other times is about 15 millimoles. So he has a horrible life with his diabetes, despite all of this trying to make decisions process. So we switched him again to a 3 times daily mix. And again, these are real life, so sadly they don't get perfect at the end. But again, what's very notable, if I flip back and forwards between the 2 slides, is that for him, that's made an enormous difference in variability. So all of a sudden, I can be much more confident about saying, oh, look, that breakfast rise was there previously, but it was less obvious because it was hidden in this wide range of glucose. Now the breakfast rise is really very specific. So now we know, yeah, this person needs a higher dose of insulin alongside his breakfast, and I can be absolutely confident that giving him that will be the right thing to do. So for me, if you combine the idea of profiling with the idea of logical and flexible therapy choicing rather than this stepwise process that we've sort of learned over the years, I think we have a meaningful way forward for the future. And this, you'll be pleased to hear, Mr. Chairman, is my last slide. I think, therefore, we have many tools. None of them is a panacea. I don't believe there is any tool that is actually any better than any other tool. I think it's just the case of that we want to use each tool to its best effect. So I think the combination of having a wide open toolbox and a way of measuring what our tools are doing is where we should be concentrating over the course of the next 5 to 10 years. Thank you very much.
Two important classes of diabetes medicine. As you know, we have obesity in our area, and also our population eats a lot in their meals. So, you know, that's probably one of the things that we have to consider. So, any questions? Questions? You want Mike, please?
Thank you very much for the good presentation. Back to the GLP-1 analogs. Do you will prescribe analogs for morbid obese with pre-diabetic stage, or the pre-diabetic stage exactly, to get both the control of the pre-diabetic stage in terms of glucose, and especially to slight decrease of weight?
I do. And what I would say is my practice around the most obese patients I see, I have 2 main areas of hospital practice, and then I also do advisory practice in primary care. So my advisory in primary care is very broad. My hospital-based practice is slightly narrower, which, as you heard at the beginning, is intensified insulin therapy predominantly in type 1 diabetes, but also I do the diabetes renal service for the local regional renal unit. And it's actually in that group that I would say I do use quite a lot of the high percentage mixes. The issues around effect, I think, are important when we get to high doses. Again, this is anecdotal. My hope being that AGP will be the way that we can start to make this a more systemic and systematic examination. But anecdotally, I think it's certainly true that people who have renal impairment and very significant insulin resistance, which admittedly is a minority, most with significant renal impairment are actually more insulin sensitive because of failure to clear, but those who have significant insulin resistance with renal do need short-acting insulin in there at a higher percentage. And I think in my practice, I mean, we're thinking about some of the other formulations of insulin that are coming forward in the future, like the higher strength short-acting insulins. And I think those, for me, are the ones that will be my first patients that I will be starting to think about it, because I think it does make a difference in getting that initial glycemic effect.
I mean, over many years, the only mix we have, especially in our hospitals and the primary care, is the 30/70. There used to be 20/80 in the past, but it's not mostly available. So, you most commonly premixed insulin you use in your hospital?
So probably if one was looking at it in terms of percentages, 30-70 in my catchment population would probably be the commonest. I think one of the challenges that we have when we only have one type of mixture that we use is that we tend to think of it as a routine process. Actually, with one type of mixture, different patients can use that in a wide variety of ways. So I use a lot of once daily premix 30-70. And I think that the issue is to think of the tool not as only being able to be used in one way. It can be used in many ways, but actually I think when you have more tools, it's easier to think of the fact that it may be used in a different way. It's, you know, I've got a Phillips screwdriver and I've got an ordinary crosshead screwdriver, and actually I could use either for both, but I will prefer to use one for each.
Any question? Thank you, Prof. Thank you for your nice lecture. إن شاء الله كان الغدا زين. Good. الحمد لله. في ناس تسوي كذي. Good. الحمد لله. عليكم بالعافية. أسامي شنو؟ يس راح نبدي بالسحب الحين. لا اللي خد امبارح ما خدش النهارده. التبديل في الأقنصة تحت. تمام يس. آخر شيء فراح يصير في سحب الحين وسحب بعد آخر ورك شوب على الجائزة الكبرى مثل ما تسميها دكتورة زينب اللي هو the latest Galaxy phone. تمام. Edge. تمام. This is our workshop was going to be talking more closely about the AGP and the new instruments that actually used to reach a blood glucose level that is more than what we used to, which is just hand prick. We understand that this is very painful to our patients, and all the companies are working hard to get people to go away from pinpricks of their fingers to ways of measuring glucose with a lesser harmful way. There are many in the pipe. There are lots of non-invasive glucose monitoring using the ears and the buccal cavity and the nose and everywhere. But it's still not to the level where we can be used commercially. We have a new instrument. You're going to learn about it today. And also feel free to stop and ask. This is not just a formal lecture. Anytime you just stop. If you don't understand, if you want to see, there are going to be some machines. We're going to go around you. If you want to have a look at it, touch it, we'll bring it to you ourselves. Okay? So we'll go with the سحب. وين؟ يلا يلا اوكي. ما ادري ما عرفت اقرا. دكتور عصام. عصام شنو ما ادري. نعم ايوه تفضل دكتور. اسمك كاتبه وانت مالك خلق شكله. تفضل. الله يسلمك مبروك ان شاء الله. بس اوقف عشان الصوره. يلا مبروك ان شاء الله. اوكي. نساء. كثيرة كويس. كبيرة الهدية الحين. دكتورة لينا الخالد. لينا كانت الرجسترار مالتي بس راحت الحين. دكتورة رنا إمام. رنا إمام. نعم. Okay. Okay.
اوكي خليها تصور.
Thank you. Just have a picture with you. Yeah. Thank you. Thank you. So we'll proceed with our program. We'll invite our distinguished guest, Dr. Ramzi, and you know him from the previous lecture. So if we finish early, then we'll start again, and then we'll finish our program earlier today. Thank you.
Stand here so
Yeah.
I can be closer to
Yeah,
people.
sure.
Yeah. Right. So good afternoon, everybody. So nice to see so many of you here today, after a long day, actually. This is going to be something that you will be doing the talking more than me, so I would need your help. So I'll have some cases. It would be very nice to have some volunteers to tell me what he or she thinks about a particular case. At the very end, 10-15 minutes at the end, you'll have the opportunity to see the device yourself and have a look at it. So just going back a couple of slides, just to remind you what we talked about this morning, that the problem with controlling glucose is this very large fluctuation in levels. So it's not like cholesterol levels, not even like blood pressure. It can be very, very challenging indeed. And the other thing to remember, that leaving the glucose too high for a long time is associated with complications. Fluctuations are associated with complications. And of course, hypoglycemia is very, very dangerous. And I'm putting up that triangle again because I think it's very nice to remember how to manage glycemia according to that triangle. And it's really important. Now, one thing that I wanted to point out to you, that this particular new device has got CGM for 2 weeks, and there is a reason why it is for 2 weeks. This is the correlation between 3-day CGM data and glucose reading after 2 months. So if you do 3 days or 5 days of CGM, you adjust treatment and you look at the glucose levels after 2 months, then the glucose levels do not correlate that well. However, when you do that for 2 weeks, you can make adjustments that correlate with longer-term control. So there's a very clear-cut reason why it is 2 weeks. So this is the device, as I showed you earlier. Insertion of the sensor is very, very easy. Even I could do it. It is that easy. It's painless. The only painful procedure is taking off the sensor because it's very sticky. It sticks to the skin, and taking it off can be slightly painful. But other than that, it's very, very straightforward. And you get a host of data from the sensor. So this is the device. I don't know how well this is projecting, but it can give you current glucose reading, that big number, 6.2. So you can do a check anytime that you like. And I said earlier that it stores reading every 15 minutes. But if the patient decides to check the glucose every minute, you can do that. So that's not a problem. And the other thing that it does, you can see that arrow next to the number. It gives you trend arrows. So it tells you the glucose is going up or the glucose has been going down. So it gives you that trend of what's going on. In the bottom, you can see that median glucose, the median glucose level. So it tells you what happened in the past 24 hours. It can also tell you what happened in the past 7 days or 2 weeks. So it gives you that profile of the glucose, which we all know very important. Single reading is very difficult to know what to do with it. So there are all sorts of things that the device can tell you. Of course, it tells you how much battery it's got left. You know, it's very similar to how mobile phones work. And then you can download the data. You can download the data to a computer, and you can have a very large host of data once they are downloaded. What I notice with my patients mainly rely on the device itself. They do not tend to download the data to a computer. Although you can get more information, they think what they get on the device itself is enough. But of course, that's down to personal preference. If you download the data, you can present the data exactly the way I showed you earlier, and we'll go through some cases regarding that. So, again, just to remind you, you get the median, you get the readings that are 50% of the readings are in that range, that the dark blue, and the light blue would be the 80% of the readings in range. It can tell you average glucose level for a particular time of the day. Also, it turns red when things are out of control, particularly with hypoglycemia. So it makes your life much, much easier so that you glance at it and you can tell what's going on. And as we said before, pattern recognition is very important. So it tells you what's going on for the past day, week, 2 weeks, or even longer. And also, on top of that, if the patient is very keen, they can input information about what they've been doing, what they've been eating. So you can put in the carbohydrate readings of for instance, I've eaten a lot of sweets yesterday. You put in the information there, and you can say, we can see whether it's corresponding to a rise in glucose. And finally, just again to make life easier, you can put in insulin data, how much insulin the patient administered. But of course, you will need a dedicated patient to put all the information in. So you can have a lot of things going on when you're analyzing the data. Now, the other thing that I quite like is that you can have the data as dots as well, because you've got here, the line there is the median, but you can see, you want to see those hypoglycemia, how often do they occur, how many of them, and actually you have quite a lot of hypos, and that shows here in red. So there are a lot of hypoglycemic readings showing in red. So you can have the individual data combined with the AGP reading, which makes it really, really nice. So these are the, as I said, the individual data, and these are the red markings for hypoglycemia. And I think you probably know by now that I'm absolutely obsessed about hypoglycemia. It scares me. After we got the local data on hypoglycemia and mortality, I'm very, very concerned about my patients going hypoglycemic. Now, one thing that my research nurse really likes to do, and I like to do as well, is to look at individual days. So we do 2 weeks of median glucose, the range, but we also look at each day, because what happens that sometimes you get a peak and it corresponds to a particular day of the week, and the patient says, oh, actually this day I'd like to relax my diet, and then you can see those peaks. So you can see the profile for each day if you like. The other thing that we notice is that some patients are getting hypos twice a week. So we go to this individual day pattern, and then it turns out that those hypos are occurring when they're doing exercise. I had a patient who was having those hypos Monday and Thursday, and then we found out that he plays football on Monday and Thursday. So it's very helpful to go through individual days as well. So this is what it looks like. You can see you've got a hypoglycemia very early in the day, around 1 or 2 in the morning, and then you get the levels go a bit too high. Tells you the average glucose level as well as the total amount of carbohydrate and insulin if the patient is inserting the data, of course. So that needs, you need a reliable patient for that. And then you can see this is sort of a whole week. You can see the individual days of the week. So after that, now I think I presented to you everything that you need to know about this device, and it is your turn now. So let's start with a case. This is a case number 1. It's a type 1 diabetes patient, 27 years old, diagnosed at the age of 12, so had diabetes for 15 years. On insulin glargine or Lantus, 42 units, and Novorapid with meals injects 1 unit for 10 carbohydrate. And this is the AGP profile. Now, the AGP profile gives you an estimated HbA1c. You can see it on top. It says that 46, but the actual HbA1c was 60 millimole per mole. The reason for the discrepancy is because the estimated HbA1c is over a week or 2, whereas the real HbA1c is over 6 weeks. So there was a slight discrepancy. I mean, we do find some discrepancy between estimated and real, so you shouldn't rely on the estimated to make decisions. That just helps you. Quite often they are very, very similar. So who is going to volunteer to analyze this AGP? Anyone? I have to pick on people. Oh, I'll tell you what, I'll be nice. I'll volunteer for the first one, and then you can volunteer for the rest. How about that? Okay? So in this particular case, okay, show of hands, who thinks hypoglycemia could be a problem? So I'm seeing some hands coming up. Who thinks hypoglycemia is not a problem? Who thinks I'm not sure, I don't know? So the majority of you are in a fourth group and I don't know what it is. Okay? So, but what's happening here, if you look very closely, it is the first line, it's not projecting that well, I'm afraid. The first line, the blue line, is your median glucose, the preferred median glucose. The second line, that black line, is the hypoglycemia threshold. Yeah? So you can see that it is dropping, the range is dropping below the hypoglycemia threshold. So actually, there is a problem with hypoglycemia here. Going on to average control, do we think the average control is good? If you look at it, actually, it is below that median line most of the time, other than first thing in the morning and last at night. So that's not too bad. You look at variability, actually variability is quite big. So if we go to the traffic light system, it's red everywhere for hypoglycemia. Yeah, so the first bit, you know, red all day, this patient is going hypoglycemic. And actually, this patient was going hypoglycemic for around 6 hours a day. So it was really very, very serious. If you look at the median glucose, at the beginning of the day, so the beginning starts at midnight, so midnight to 5 a.m. is high, but then after that, the median is not bad. So during the day is okay. Variability, pretty bad, first thing in the morning, last thing at night, and in between, it is not that great. So, what did we do in this patient? We re-educated. We avoided large corrections because this patient turned out what he was doing, that glucose very high, he will give correction doses of insulin, and they were very, very high. He will go hypoglycemic, then corrects the hypoglycemia, goes up, and he was yo-yoing up and down. The other thing that we've done is we reduced the basal insulin as well. What was very interesting, the patient after this reported less headaches. People with severe hypoglycemia, repeated hypoglycemia, you'll be surprised how many of them get headaches the day after. And they can't concentrate at work, they can get irritable and so on. They can get very non-specific symptoms. And he started reporting, I'm getting less headaches. Ready for further education and carbohydrate counting. Now the HbA1c, as you can see, has gone up to 70s. It was 60, has gone up. But of course, this is because we concentrated on getting rid of the hypos altogether. So from my point of view, I don't mind the HbA1c going up for a short while until you get rid of the hypo, and then you can concentrate on reducing the glucose further. So as you can see, we reduced the risk of hypoglycemia drastically. We haven't eliminated it completely, but we reduced it quite a bit. Median glucose now is above the line where we wanted it to be, but that's not a problem. We can always work on that later. But variability remained high. The reason variability remained high, that this guy was still very worried that when he saw glucose is too high, I need to give correction doses. I'm not a big fan of correction doses, but this is what happened. I'm pleased to report, though, that after a while, after 6 months later, I haven't got the data here, the HbA1c actually fell to 55 and no hypoglycemia with this guy. We needed to do a major, major re-education. So this is how he started on the left, and this was after 3 months on the right. And it took another 6 months to get his glucose properly under control. But as you can see, the hypoglycemia is far less a problem after 3 months. So to summarize this case, he was running 5.3 hours a day in hypoglycemia. We managed to reduce that to 0.6 hours a day. Time in normal glycemia decreased from 12.6 to 9 hours. HbA1c increased as I showed you, but 6 months later, it was much better. Okay? So let's do case number 2 out of 97. No, there won't be 97 cases, don't worry. So this is case number 2. This is a 63-year-old gentleman, type 2 diabetes for 9 years. He's on Novamix 30, so mixed insulin, yeah? And of the mixed insulin, he's on 49 units in the morning and 36 units in the evening. This is his profile. So his estimated HbA1c was only 48, but his real HbA1c was 65 millimole per mole. Who's going to volunteer here? And remember, try to go with the triangle: hypoglycemia, high glucose, and variability. Anyone? I can see a lot of faces who would like to volunteer. I'd rather not pick. What do you think? Yeah, please. Right. So hypoglycemic risk, what do you think? Right, I'll come to you so people can hear you.
So there is early morning hypoglycemia, right to midnight, as you said, and there is a hyperglycemia. And again, midday and in the evening, he is going into hypoglycemia.
Well, that's absolutely fantastic, because it's really difficult to spot that hypoglycemia. You can see it at early morning, late at night. You're absolutely right. And then there is that peak in glucose. Looking at the median is not too bad, except for that peak. So this was the situation. So you've got the hypoglycemic risk, as you pointed out, beginning and end of the day, and there was a little bit in the middle, but I'm not too worried about that. And then there was that peak is well above the median when it comes to the glucose levels. Variability, not terribly bad. You know, there's some variability, but not terribly bad. So my question to you is, what would you do?
I would like to decrease the dose for the basal.
Sorry?
I would like to decrease the basal dose.
He's on mixed insulin.
Oh, sorry, yeah. We can decrease the evening dose in this case so that he can save the late night.
So increase what? Increase the morning dose.
No, I would like to decrease the evening dose.
Decrease
So
the
that-
evening dose. Okay. Yeah, I'm with
so
you.
that- so
And
that
what
we
else?
Yeah. I think the rest of the day he is doing well.
Right. So you decrease the evening dose of insulin. What happens to that peak? You've got a peak in the morning.
Yeah.
So what would you do with that? Anyone?
So he would like to add some ectopate in the morning with the breakfast.
So you want him on BD mix plus short acting. So you're effectively switching to basal bolus, more or less.
Exactly.
An option. The patient says, absolutely no way I will go more than 2 injections a day. I don't want more than 2 injections a day. Fair enough. That's a very good point, that the peak could be due to the fact that it's hypoing earlier. But the hypo, if you look at it, is quite early on. There's quite a bit of lag for that. But it's a very, very good thinking. Yeah, it is a possibility, but he says, I don't usually feel the hypos and I don't do anything, but he loves to have a big breakfast. He's very keen on big breakfast. So what else can you do? Diet, yeah, educate on diet. Say, well, have a slightly smaller breakfast. Absolutely not. He loves his breakfast. Refusing. Very good. Very, very good. Remember, you can change the mixture of insulin. So what happened here, we switched to a different mixture. We went for Humalog 50 in the morning, Humalog 25 in the evening, and this is what happened. So if you look at it, the hypo risk, there's a very slight hypo risk at the end of the day, but it's not in red, it's sort of yellow, giving you, so be careful about that. The median glucose is beautiful, as you can see, and the peak has completely gone. And another minor tweak, and this is what we got, really hypoglycemia is not a problem anymore, very good control, real HbA1c is 48 millimole per mole. You can't ask for anything better than that on a BD mixture insulin. So this is the before and after AGP profile. And what I would like you to sort of to concentrate on that, if you look at the profile, is not drastically different, but there are very big changes in HbA1c. HbA1c fell from 65 to 48, and then the risk of hypo is much, much lower. So sometimes you make very small changes in the insulin, resulting in very big changes in HbA1c. So the summary, time in hypoglycemia was reduced by 0.1 hour a day. I mean, he was